go straight on to Dr. Malcolm Lewis, who's my colleague, or ex-colleague from Manchester Children's Hospital, who's got some experience in looking after young people with this condition from the bladder point of view. And it's a great pleasure to welcome you, because I think you've come from Dublin as well to come and visit us today. I can only see this is a picture of you, Malcolm. So very grateful for you coming to talk to us.
At one point in my youth, I did have long hair, but I never looked like this. When I started trying to put these slides together, I thought, how nice if I could just go onto Google, as everybody does, and get a picture of DJ Wolfram, who described the condition in 1938. And so I went onto Google Images, typed in DJ Wolfram, and up came 1,000 pictures of this chap. And he's a musician. And he has albums out and all sorts of things, and has anybody ever heard the music of DJ Wolfram? Neither did I, until I just found out who he was. And it wasn't wonderful as far as I can see, or my personal taste. But as I had something to fill the middle of the slide, I thought I'd put him there anyway. And you can all now go and download some DJ Wolfram music, and you may well find that that is appropriate accompaniment to the meetings. So what I thought I'd do for this talk is go through the normal bladder physiology, how the bladder normally works, what problems there are in Wolfram syndrome, how we might monitor problems and patients who have got Wolfram syndrome, what we can do, knowing that at the moment we can't reverse the natural trend and the neurological deterioration there are, briefly touch on some research aspects, and then tell you what I told you. So, the bladder is often taken for granted. There is a cycle. We've got a bladder over here, and it fills up, and while it's filling up, the pelvic floor is contracted, so that you're walking around, your bladder is filling up, and nothing is leaking out. And you get the first sensation of your bladder being stretched, and that is actually not the bladder squeezing, that is actually stretch receptors in the bladder wall telling you the bladder is stretching. And when the bladder's stretched, you don't just pass urine, you think, I'm in the middle of Tesco's, this is not the time to do it, and you suppress that desire to pass urine. And then you get to the point where you feel your bladder is definitely full, and you still suppress things until you get to the right place, when you do two things. Firstly, you allow your bladder to contract, and secondly, you relax the pelvic floor and the muscles that help hold it in so that it comes out with a whoosh. And that's one of the things I'm always asking, do you wee with a whoosh? And there's a lot of neurology that's involved with that. So there's brain control up in the pons, down through the spinal cord, and through to the urinary bladder. And I'm not going to go into all the different nerves that are involved, but there's a lot of nervous pathways that decide whether the sphincter is contracted or relaxed, and whether the bladder is squeezing or not. And this is a tracing from urodynamics. So when people get bladder problems, they'll often have what's called urodynamics performed, where catheters are placed in the bladder, fine tubes, so that you can both fill the bladder and measure the pressure in the bladder simultaneously. And what you find with that is that there are several pressure lines on the graphs. They come in different orders, but you've got a volume, the amount that's been put in the volume in the bladder. You've got the pressure measured in the bladder, and then usually there's a little probe put in the rectum as well, so you can measure the general pressure in the tummy through the rectum. And the difference between the two is the actual squeezing of the bladder. So if the patient coughs, you get a rise in the pressure in the bladder and a rise in the pressure in the bottom, and so that stays flat. Whereas if the bladder squeezes, then you get a rise in the pressure in the bladder, no change in the bottom, and so you see it's the bladder that's squeezing. And here, this is a normal trace, so the bladder is floppy all along until the patient goes to wee. And this is an electrode, so to put around the bottom to see how much squeezing of the muscles and the pelvic floor is going on. So all the time during filling, there's activity there, and that activity is the muscle squeezing. And then when the patient goes to wee, what you find is that activity goes away, so the patient relaxes, and the pressure rises, and the urine can come out. And the combination of relaxing those muscles and squeezing that muscle, and that coordination, is very important. So, what problems do we get in Wolfram syndrome? Well, actually, it's the same sort of problems that you get in all different patients from different conditions with the bladder. So, you can get what's called an overactive bladder. An overactive bladder is very, very common in the population to varying degrees. It's very common in children. An overactive bladder is simply a bladder where the bladder muscle is squeezing when it shouldn't do. And it's very common in children. I'm seeing lots of children with it. So you will all see your own children or children's friends or whatever who, the little boys, they suddenly feel they need a wee and they're like that. Or the little girls, they're crouching down with their heel between their legs. That is actually one of the great male advantages. Because when you get that bladder spasm and you grab yourself, you can run. Little girls crouch down. They're in the middle of the aisle in Sainsbury's or Tesco's or whatever. Nothing can be done. They can't move. So there is a male advantage to if you've got an overactive bladder. And that feeling will go away. That spasm will go away after a while. Sometimes the children have wet themselves, sometimes not. And then you can get an atonic bladder, a bladder that just won't squeeze. And then the bladder fills up more and more and more until it's just overflowing and coming out. Or you can get what was first really described with Wolfram syndrome, and which is perhaps the most typical finding, but doesn't happen in all patients, and that's what's called detrusor sphincter dysnergia. And it's a lovely term with a very strange spelling of dysnergia, but that is the way it's spelled. And what that means is that the bladder and the sphincter are doing opposite things. So you'll get the bladder squeezing when it shouldn't do, but then when you actually go to wee, instead of squeezing the bladder and relaxing the pelvic floor so that it just comes out, both squeeze. So the bladder squeezes, but the pelvic floor squeezes. The urine will only come out with a bit of a trickle, but you're creating a very high pressure in the bladder because the pelvic floor isn't relaxing and the urine can't get out, but the pressure in the bladder is rising, and that's the thing that causes back pressure on the kidneys and dilatation of the kidneys and kidney damage. And the consequences of all those things, you can get incontinence if you're leaking, but if you've got the detrusor sphincter dysnergia and the urine isn't getting out properly, then you get hydronephrosis, which is the dilatation of the kidneys, and the kidneys can get damaged slowly with time. And then, if you're not getting your bladder empty properly and you've got stasis because you're not managing to empty properly, then you're much more prone to getting urinary tract infections and also getting stones developing, which is what the calculi are. And this is just a diagram of an overactive bladder. So we've got normal bladder on the left-hand side there and a contracting bladder on the right. And at this point, there's contraction of the muscles of the pelvic floor in both of them. And so this is just a bladder which is squeezing when it shouldn't. And here you can see the urodynamic trace just during the filling phase of this bladder squeezing when it shouldn't do. And you can give drugs to relax the bladder that don't stop people from weeing altogether, but can cut out those contractions and allow people to build up their bladder capacity. This is just a picture, a CT scan of somebody who's got an atonic bladder, so you can see that this is a sideways cut down the middle there. There's the spine. And you can see this enormous bladder there that isn't being emptied properly and is just trickling out. And this is a diagram to try and demonstrate, and somebody will point out the mistake in this because I've stolen this from Google, but to try and point out what happens when you get a bladder with detrusor sphincter dysnergia. So you've got a sphincter which is tight all the time, and initially what happens is the bladder gets thick-walled because, like any muscle, it's exercising, it's squeezing harder and harder to try and get the urine out, and so the muscle gets thicker. and then the muscle actually becomes very stiff, and you get these saculations in the bladder wall, and then those develop into bigger diverticuli, and once they've got to this stage, the bladder's not really very salvageable in terms of being able to get it to relax. But you also get the back pressure on the kidney, one or both. It can be both, sometimes it's just one. It's difficult to explain why it happens to one in some cases. But the reason I'm really lying to you with this slide is that whilst I'm using this to demonstrate what happens with detrusor sphincter dyssynergia, which can happen in Wolfram syndrome, this is actually a slide to demonstrate what happens to elderly men like myself when the prostate gland gets big. So that's why I'm lying, but the process is the same. And I had to put this up so that Tim can see it more than once in a day because it was the seminal paper. And all I wanted to point out was that what's on this slide says renal. And that's a late onset, that's peaking at about 20 years of age. But it says renal, and I think, unless I've misread your paper, so you have to correct me, that's because people were developing hydronephrosis at that point. And if you want to try and prevent these problems, then you've got to slide back. So we need to be screening patients at a much earlier age. And I will say later, preferably from the age of 5, and then Tim has said this morning people aren't getting diagnosed till 9, but the earliest possible so that you can try and prevent problems, because you don't want to peak here of renal problems, you want to be dealing with bladder problems and not getting kidney problems. So, how do we monitor? Well, clinical history is the most important because most people will start off with a normal bladder and not everybody will develop a bad bladder. There will be deteriorations, but you don't want to be doing things to patients unless they need something to be done. So the clinical history is really very important in terms of, are there problems with continence? And are those problems with continence outwith what you would normally see in children, because children have continence problems? Or are they simply explained by the high degree of urine production because of the diabetes mellitus, or the diabetes insipidus, or the combination? Because the problems with the bladder and Wolfram syndrome are made much more complicated by the fact that children normally who have, say, an overactive bladder learn pretty quickly, if I don't drink too much, I'm less likely to wet myself. Well, that doesn't work if you've got diabetes and you're producing a lot of urine. So you've got to take a good history. You've got to find out whether people are weeing with a whoosh, how much they're voiding on one occasion, have they got a small bladder, have they got a large bladder, and take a good history to work out what's going on. An ultrasound scan is very useful, and I would certainly recommend that patients have an ultrasound scan at least once a year. That's not just to monitor the kidneys to see if there's any back pressure, it's to see how much, when the patient feels their bladder is full, they can hold on to, and also whether they're emptying properly. If you scan again after voiding, is the bladder empty or virtually empty? And then if you're finding abnormalities on the ultrasound scan and the patients have got symptoms, or perhaps even if the patients are not telling you they've got symptoms but the ultrasound scan isn't normal, that's when you need to go onto the urodynamics to find out exactly how that bladder is working to come up with a plan of treatment. And in terms of checking kidney function, that needs to be done if you find that there's a problem with the kidneys. But ordinarily, if the kidneys are alright, then you won't need to do the blood tests to check kidney function. And that brings us on to what can be done. Well, for overactive bladder, the basis is bladder training. Actually, for children who have got an overactive bladder that's squeezing all the time, they've actually got to be told to drink more. Not usually a problem with Wolfram syndrome because of the diabetes, but to drink more, to practice holding on, to try and stretch up the bladder, to get used to holding reasonable volumes. And that, together with drugs to help relax the bladder, help. And the drugs that you use there are various different groups of drugs. Anticholinergics are the most common drugs, like oxybutynin, tolterodine, solifenacin, drugs like that all help relax the bladder. Myrbetriq is a new one on the street but seems to work reasonably well in combination. And then if you've got somebody whose bladder just won't stop contracting, then you can actually inject Botox into the bladder to help relax it. Not paralyse it so they can't breathe, but help relax the bladder. And I've done that an awful lot in children, though not in Wolfram syndrome as yet. And then if you've got somebody who's got detrusor sphincter dysnergia where they're not relaxing the sphincter, then sometimes drugs which are also used in prostatic hypertrophy, like doxazicin, which help relax that muscle, alpha blockers, can be used to improve the urine stream. But that's a balance because they also drop people's blood pressure. So there's no point in having somebody who's relaxing enough to wee, but then they faint. In terms of the atonic bladder, then the fulcrum for an atonic bladder is catheterization. What you need to be able to do is to hold on to a good amount of urine. An atonic bladder will hold on to a good amount of urine, but they can't empty. And the only way of dealing with that is to actually catheterize. Placing a catheter in the bladder, letting the urine out, taking it out, throwing it away. That's the most common way of dealing with that. That's a good way of giving people continence. But there are problems if you've got poor vision. So intermittent catheterization can be urethral in boys and girls, or if there's visual problems, then you can use what's called a Mitrofanov stoma, and I'll come on and show you what that is in a moment. And the other thing that can be used is a suprapubic catheter, a catheter that's left in to the bladder through the front, which is very rarely used but can be used. You can leave catheters in continuously at the bottom, or you can have what's called a urinary diversion, but those are last resorts in the very difficult cases. So this is diagrammatic of self-intermittent catheterization. I don't think I need to go too much into the details of that. Both boys and girls can achieve it, but if you've got visual problems, it does make life a lot worse. And therefore it's just much more difficult to achieve if you've got to go there. This is the diagram of forming a Mitrofanov stoma after the French surgeon who's called Mitrofanov. Isn't it interesting that people who have syndromes or make great advances in medicine never had a simple name like Smith? You never get the Smith procedure. They've always got posh names. So, with a boring name like Lewis, I'm never going to be famous. Not that I particularly want to be. So, what you can see here is the bowel and the appendix, which was always thought to be useless. And what you do is you take the appendix, you open up the end, and you put it into the bladder. And then you take the other end of the appendix and bring it out and bring it to the skin. And then you've got a track which goes from the skin, sometimes at the belly button, sometimes to the side, into the bladder. The bladder wall is squeezing it there so it doesn't just leak all the time, but you can put a tube through that into the bladder, so you're catheterizing not down from down below, but from the top to let the urine out. And I've got some pictures there. You can see this is a lateral hole, and this is a more central hole where people have got some Mitrofanov stoma so that they can drain their bladder. And certainly if you've got visual problems, then that's an easier way of draining the bladder than just trying to catheterize down below. This is a suprapubic catheter, so it's just a tube which is placed into the bladder. It's a very easy first manoeuvre if people have got problems, and I had patients who have wanted to keep that long term. There's no that I got from the internet. I haven't got a picture of one of my own patients with a suprapubic catheter, and there's no actual need for stitches there at all. I don't know why somebody's put a stitch in there. There's a balloon on the end of the catheter, and so that holds it up. And once a track has formed after a few weeks, those catheters can just be changed and replaced with a new catheter without any need for an anaesthetic or anything like that. You just have a hole that's left, so you take out one catheter, put a new one in, and then you can have a valve on the end of the catheter so that it's drained intermittently rather than being drained to a bag all the time. Occasionally with children, and I haven't done this in Wolfram syndrome, but I have done this in other patients who have needed bladder drainage. We've actually used the gastrostomy buttons, so the buttons that you usually use for feeding that go in the stomach, I've actually used those in the bladder so that you've not got a piece of tubing dangling, and you just sort of connect the tubing when you want to drain the bladder. So that can be done as well if you want it to be a bit more discreet. And then therapy for detrusor sphincter dyssynergia is really a combination of dealing with the overactive and the bladder that won't empty. So it's got to have a combination of treatments. And sometimes you need both to relax the bladder to stop it from squeezing to reduce the pressure, but you also then need to start catheterization to drain. And if medication fails to work in those conditions, then with time the bladder may well deteriorate, and in those conditions you may well need some form of urinary diversion, and that's either what's called a continent diversion, i.e. you use the patient's own bladder and just make it bigger, or you have a bag. So this is what's called a bladder augmentation, a schematic version of a bladder augmentation. So this is the bowel, and the bowel is cut. The ends sewn together, you don't miss a few inches of bowel, and this piece of bowel can be sewn along the edge there, so you've got a flap. And that flap of tissue, if you cut the bladder open, can then be sewn onto the bladder and brought down to make the bladder bigger. And that means that you've got an enlarged bladder, and it's able to store more urine, but of course because there's bowel in the way you won't necessarily be able to drain very easily, so that's best done together with a metrophthalmostoma so that catheters can go in and drain. I'm telling you what these things are. These are not things which are necessarily going to be needed, but this is how things can progress with time to show that there are means of developing continence. The other alternative is to just use a small piece of bowel and connect the tubes, the ureters from the kidneys into that and bring it out to the stoma, so you can put a bag on that and the urine can drain continuously. And some people find that easier than catheterising all the time. And then I was just going to mention briefly, I was looking things up and saw that there was studies on dantrolene and sodium valproate being started, and so I just thought I'd look up and see what has happened with the bladder and those medications. And certainly back in 1980 there was experience using dantrolene to actually relax the sphincter in patients who had too tight a sphincter and the pelvic floor was too tight. But that's certainly never caught on for one reason or another. And interestingly enough, in patients who have had obstruction and a high pressure bladder, well, rats who have had a spinal cord induced injury, then the bladder improves when you give them dantrolene. So whether that will translate into the dantrolene having a direct effect on the bladder, I don't know. Interestingly enough, with sodium valproate, then what's been found is that on a sort of animal model using sodium valproate, that sodium valproate actually reduces the fibrosis in the bladder as bladders deteriorate. And what was found is if you look at the development of collagen in the bladder as the bladder is shrinking down, then this is without treatment, and much less was fibrous tissue and scar tissue was laid down in the bladders of these animals when sodium valproate was given to them. But the best effect was at this level of sodium valproate, and the normal therapeutic level in the blood is here or below. Now, I don't know for the trial what sort of therapeutic levels are being targeted, but that's just a theoretical. So, to summarise, bladder involvement is frequent in Wolfram syndrome, particularly as time goes on. The primary symptom will be incontinence. You can get kidney damage if there isn't active monitoring, and that's why I think that it's very important to regularly monitor people from the time of diagnosis. I put their 5th birthday here. The management is undoubtedly complicated by the excess urine production that patients with Wolfram syndrome have because of the diabetes of both sorts. But there are interventions and operations which are available if, as an individual, you've got bladder problems. There are things that can be done. And all interventions have to be done on an individual patient basis. You've got to think about you can't generalise. You've got to think about what does any one patient, what's going to be best for them with their visual problems, etc. You've got to sort of look at the individual as opposed to, well, this is what you do generally. But that's what we should be doing in medicine anyway, I believe. And that's it.